Bismillah ar-Rahman ar-Rahim. Second talk is about the imaging of bone tumors, and you all know that there are a lot of ways to handle this problem, and actually the books deals with this diagnosis of bone tumors by many approaches, and I will try to present to you a different approach, which is, in my opinion, is more easier from the clinical point of view. These are the imaging modalities used for assessment of the bone tumors, including the very important one, which is the plain X-ray. And we may still use the conventional tomography, which is largely replaced by CT, ultrasound and bone scan, as well as the MRI and the angiographic techniques. Actually, the plain X-ray is very important in assessment of the bone tumors because it provides most of the necessary information to predict the possibility of the tumor. And this is a very important statement that the X-ray should never be omitted in the investigation of bone tumors. If you can have the plain X-ray, it will be very helpful. And I usually advise my junior colleagues, if they are confronted by a CT scan of a case of bone tumor, please look to the scanogram, which provides a lot of data concerning the tumor. Then what do you want to know about the bone tumor in order to reach the diagnosis? Number one, you want to know the site, because epiphyseal lesions can have certain differential diagnosis, and so the metaphyseal and diaphyseal pathology. This is an epiphyseal lesion which is characteristic of a chondroblastoma, as we will mention, and this is a metaphyseal lesion which is diagnostic of an osteosarcoma, and this is a diaphyseal lesion which is classic for an Ewing sarcoma. Then you want to know the nature of the lesion, if it is expanding or destructive. Most of the expanding lesions are benign, and most of the destructive lesions are malignant. Then you want to know about the margin. If the margin is well defined and sclerotic, you are almost dealing with a benign lesion. If the margin is ill-defined and you cannot see the margin, you are dealing most probably with a malignant lesion. Then you want to know the matrix. If the tumor is cystic or not, if it contains calcium or not. Cystic expanding lesions are mostly benign, while lesions containing calcium are not necessarily to be benign, because one of the characters of chondrosarcoma is the presence of matrix calcification. This is an ordinary enchondroma, as we will mention in a moment. Then you want to know something about the periosteal reaction. The candle wax periosteal reaction is characteristic of infection or inflammation, osteomyelitis, while the onion peel periosteal reaction is characteristic of an Ewing sarcoma. The sun ray speculations with Codman triangle are the characteristic of an osteosarcoma. Then the use of conventional tomography may be resorted to in some cases, like osteoid to see the nidus, for example, which in most of the cases is hidden by the extensive periosteal reaction around the lesion. Ultrasound is used to assess the extraosseous soft tissue component. It is real time. It can differentiate by the cystic from the solid masses. It can characterize the tissue according to the presence of fat or blood or calcium. You may use the Doppler facility to identify the tumor vascularity, and also use the ultrasound to guide the needle for aspiration and the biopsy. Then the CT scan is better for assessment of the extraosseous soft tissue component, especially if it contains calcium. This is one of the major issues by CT. Then it can help in assessment of the neurovascular bundle, which is also evaluated accurately by MRI. The use of 2D and 3D images are also of help to assess the tumor nature and extension. Then, whenever to use CT scan, you are aiming at certain points, especially in the spine and the pelvis, where the plain film findings may be equivocal. Also, in assessment of the tumor margin, if it is sclerotic, like this osteoid-osteoma and this chondroblastoma, and this tumor margin is ill-defined of an osteogenic sarcoma. Then to see the periosteal reaction and to detect the extraosseous soft tissue extension. The bone scan, as you all know, is sensitive but not specific. It says this is a pathologic area, but it cannot say accurately what is this unless you have the clinical finding and other imaging data. And this patient with mid or dorsolumbar back pain, and you can see this is sclerotic deformity, bone scan pointed to the presence of an increased uptake in the pedicle of the 12 vertebral body, which was proved to be an osteoid-osteoma, for example, that was not clear in the plain X-ray. Then the use of MRI is concerned with the detection of bone marrow. The first role of MRI in imaging in musculoskeletal imaging is detection of bone marrow lesions. Then the bone marrow infiltrations can be easily delineated by MRI, as I will show it to you. This is the extremity magnet, which has been mentioned this morning, and this is the dynamic MRI. This dynamic MRI can scan the patient while standing or semi-erect or in the supine, and it has a major role in assessment of postoperative spine and other pathologic entities in the spine. Then, how to perform the MRI for a limb or for an area which contains a suspected bone tumor. Number one, if the tumor is in the lower limb, like most of the tumors, you should have a scan for the whole limb to look for skip lesions in some cases. And you should have a scan for both limbs for comparison, for any bone marrow abnormality, residual red marrow, and other pathologies. Then, what do you think about this tibia? It looks like a normal tibia, but the MRI showed that there is an extensive marrow infiltrative lesion, which has been proved to be an Ewing sarcoma. The whole body MRI is a scan which can be performed for the whole body in the frontal view and in the lateral view. They said in the literature it is more superior than the bone scan in screening the human body for metastasis, because besides it can see the bone, it can also see the spinal cord, it can give a crude idea about the brain as well as the muscles in the limbs. Then how to know the pulse sequence? The pulse sequence is known by the appearance of the fat. The fat is bright in the T1 and less bright in the T2, less bright in the gradient image or T2 star, and very dark in the stir image. Then the fluid is of low signal in the T1, high signal in the T2, like the fluid in the articular cartilage of the patella and the femur, which is of low signal in the T1 and high signal in the T2. The fat is the opposite of the fluid. The fat is bright in the T1 and dark in the T2. Then this is the protocol for evaluation of the bone tumor in my point of view. I have classified the bone tumors into 3 categories. The first category, what I call lesions with characteristic imaging finding. You can say these are the spot diagnosis. Then if you see one of these lesions, you can safely say this is so and so. Then another group of lesions where you can suspect the diagnosis, and the diagnosis is confirmed by another imaging modality or by biopsy. Then this group of lesions, you cannot suspect the tumor, but you only say this is a benign or malignant. This is what you can say in this group of patients, and you go directly for the biopsy to solve the problem. Then we start with the first group, which is the largest one, and it includes about 9 tumors: osteoma, osteoid osteoma, osteoblastoma, enchondroma, chondroblastoma, osteochondroma, non-ossifying fibroma, and fibrous cortical bone defect, and giant cell tube. We start by the osteoma, which is the ivory osteoma, or the osteoma which does not contain a medullary cavity. There is no cancellous bone in this osteoma, and it is an easy diagnosis. If you see an osteoma like this, which is commonly present in the paranasal sinuses, like this osteoma in the frontal and this osteoma also in the frontal sinus. This is an easy diagnosis, the ivory osteoma. Then you go to the second one, which is the osteoid osteoma. The osteoid osteoma is a radiolucent lesion with a sclerotic cortex and maybe a central nidus of calcification. And if you look to this lesion, which is a classic for osteoid osteoma, you can see a radiolucent lesion. This is the whole nidus. The nidus may contain a fleck of calcium which is central in position, and this lesion will show a increased uptake by bone scan. This is one of the commonest musculoskeletal tumors. It occurs in represents about 10% of all benign tumors of the bone. And this is the osteoid osteoma by plain X-ray and the osteoid osteoma by CT. If you see this classic appearance, you can safely say this is an osteoid osteoma. It is a radiolucent lesion surrounded by extensive perosteal reaction and thickening of the cortex with some calcific foci in its center. Then you came to the third lesion, which is, if located in the spine, you can spot it. If it is located in the long bone, it will be difficult to be diagnosed, which is the osteoblastoma. The osteoblastoma is similar to osteoid osteoma but bigger in size. Osteoid osteoma is less than 1 centimeter or less than 1.5 centimeter, but the osteoblastoma is larger. Then this is the age, and many of the lesions occur in the spine, especially in the region of the pedicle and the posterior elements. The lesion is expanding. It contains matrix calcification like the osteoid osteoma, but it is sizable, and the calcium is not central. In osteoid osteoma, the calcium is in the center of the osteoid osteoma, but in osteoblastoma, the calcium is distributed in the tumor. Then if you see a lesion like this involving the pedicle and the lamina with expansion and extensive bone sclerosis around, matrix calcification, in this age group, he can easily diagnose the possibility of osteoblastoma. And this is an osteoblastoma of the sacrum in a male patient 16 years old. In the plain X-ray, you can see a sclerotic lesion in the, in the first sacral piece with compression of the contrast column of the myelographic study. Then if you look to the CT, and you can see an extensively calcified lesion filling most of the spinal canal, compressing the ceca, which is filled by contrast. And this is the bone window, this is the cecal sac filled by contrast, and this is the lesion, and you see this is a sclerotic reaction around. Then you came to the fourth one, which is the enchondroma. The enchondroma is a benign tumor which affects mainly the tubular bones of the hand and the hands and the feet. It can also occur in the long bones, in the medullary cavity of the long bones. If it occurred in the short bones, it will be of expanding character, and any chondro lesion will show some matrix calcification, like this enchondroma in the terminal phalanx and this enchondroma in the middle phalanx with pathological fracture. If the enchondroma occurred in the long bones, you can also easily see this lesion. You remember the calcified lesion in the medullary cavity of the knee, and this is the classic appearance by MRI. The lesion is black in the T1, bright in the T2, while the matrix calcification will appear black in both T1 and T2. The sclerotic cortex will appear clearly in the T2 weighted image. Then if the patient had multiple enchondromata, this will what is called Ollier disease. If the enchondromata are associated with hemangiomas, identified by the presence of multiple soft tissue fleboli, then this is Maffucci syndrome. And this is Ollier disease, where you can see multiple enchondromas. This is an enchondroma, another one, another one, another one. This is Ollier disease. Then you came to the fifth tumor, which is the chondroblastoma, which is characteristically an epiphyseal lesion occurring before epiphyseal closure. And if you, this is the epiphyseal line, and this is an osteolytic lesion in the head of the humerus. Any chondro lesion should have some calcium inside, and the calcium is better detected by CT. And you see, this is the classic appearance of a chondroblastoma in the epiphysis of the femur, and it has crossed the epiphyseal line and it has a small component in the metaphysis. Then this is an epiphyseal lesion because the main bulk of the tumor is located in the epiphysis. And calcium, of course, will appear black in the T2 image. The sixth one is the osteochondroma, or what we call the cartilage-capped exostosis. The osteochondroma is a bony exostosis with special characters. Number one, it has a medullary cavity with a cancellous bone that is continuous with the medullary cavity of the mother bone. And it is capped by cartilage, which is better seen by MRI. And it may contain matrix calcification because of the chondro element of the tumor. Then there are two types of osteochondroma, the pedunculated one and the sessile one. But both lesions should have a medullary cavity, which can discriminate the osteochondroma from the ivory exostosis. This is an MRI T2 or gradient image showing the cartilage capping the exostosis. In the T2 weighted image, the cartilage will appear bright because of its water content. The normal thickness of the cartilage does not exceed 1 centimeter. If it is more than 1 centimeter, with erosion of the underlying bone, then you are suspecting the development of malignancy, the change of osteochondroma into a chondrosarcoma. And this is a malignant transformation in an osteochondroma. By plain X-ray, you only identify destruction of the apex of the osteochondroma. By CT, you can see the destruction more better, and you can judge the thickness of the cartilage cap. By MRI, you can see better the thickness of the cartilage cap and the destruction of the underlying bone. Whenever osteochondromas are multiple, then you are dealing with the hereditary exostosis, or what we call diaphyseal achalasia. And you can see this is an autosomal disorder, autosomal dominant disorder, characterized by multiple osteochondromata and abnormal bone remodeling, as you can see in this case. Then the next one is the non-ossifying fibroma, fibrous cortical bone defect. You know that the fibrous cortical bone defect is a marginal sclerotic lesion which is located adjacent to the cortex of the bone without significant deformity of the medullary cavity of the affected bone. The books identified the fibrous cortical bone defect by this appearance up to the age of 8 years. After the age of 8 years, this fibrous cortical bone defect should heal and should fill with calcium and bone. If it did not fill or heal, it will turn into what's known as the non-ossifying fibroma. But actually, the books usually write the diagnosis like this: non-ossifying fibroma, fibrous cortical bone defect, because both are intimately related, and sometimes you cannot discriminate both lesions on the basis of radiology. I assume that whenever the lesion is like this one with no deformity of the bone, you may assume this is a fibrous cortical bone defect. But if there is expansion and the cortical bulge and the endosteal thinning and then you may suspect the non-ossifying fibroma. One of the golden advices is not to diagnose any fibrous lesion by MRI. There is a great incidence of error in the diagnosis using MRI for assessment of these particular issues. then the plain X-ray is very simple, and you may reach the diagnosis very easily. The last one in this group is the giant cell tumor, and the giant cell tumor characteristically occurs after epiphyseal closure, and this lesion is an expanding lesion, and it characteristically reaches the articular surface. These are the criteria of the giant cell tumor, or what we call the osteoclastoma. It is a locally malignant tumor, may turn malignant in about 20% of the cases. In order to diagnose giant cell tumor, there should be a metaphyseal lesion which reaches the articular surface and occurs in the bone after epiphyseal closure. These were the first group, where if you look to the X-ray or the CT, and you can easily reach the diagnosis. Then came the lesions with suggestive imaging criteria. The osteosarcoma, Ewing sarcoma, chondrosarcoma, aneurysmal bone cyst, simple bone cyst, metastatic deposits, and multiple myeloma. We start first by the malignant criteria. The malignant criteria, number one, is ill-defined margin, the benign, well-defined margin. Cortical destruction, the benign cortical expansion. Periosteal reaction, there is no periosteal reaction in the benign lesions. Extraosseous soft tissue component, there is no extraosseous extension in the benign lesions. Then, the most two important issues in the malignant criteria is the cortical destruction and the extraosseous soft tissue component. If you see cortical destruction and an extraosseous soft tissue component, you assume malignancy, and you start to do the differential diagnosis. This is a classic appearance of an osteosarcoma in the metaphysis of the femur, with the classic Codman triangle and the sun rays speculations of the periosteal reaction. The first one is osteosarcoma, and osteosarcoma, as you all know, occurs in about half of the patients in around the knee. It is metaphyseal and it is eccentric, and it shows the classic appearance of the periosteal reaction, including the Codman triangle and the sun ray periosteal reaction. By CT and MRI, you can identify the extraosseous soft tissue component of the tumor. Then this is an osteosarcoma of the humerus. You see the sclerotic reaction, you see the pathological fracture, and in MRI you see the bone marrow infiltration by the tumor, the extraosseous soft tissue component, which can be easily seen in the axial images. They usually said that the extraosseous soft tissue component is eccentric in cases of osteosarcoma and circumferential in cases of Ewing sarcoma. This is not a solid rule. And this is an osteosarcoma, and you should have the opposite side for comparison. This tumor extends in this area, and this is the plain X-ray of the diseased limb and the sound limb, and this is after contrast enhancement. And I usually say that the diagnosis of bone tumors is better before contrast injection rather than after contrast injection. Then here you can see the extraosseous soft tissue component, which is enhanced, almost similar to the fat. But if you have the non-contrast image, you see this tumor in a good way rather than this one. Okay. Then you came to the Ewing sarcoma. And Ewing sarcoma classically occurs in the metaphysis, in the diaphysis, with a good incidence of sclerosis in the medullary cavity, and this very characteristic periosteal reaction, which is known as the onion peel periosteal reaction. Then if you look to this humerus, you can see the pathological fracture. If you look to the MRI, you can see the bone marrow infiltration by the tumor, the axial contrast enhanced image, and you can see the tumor which is enhanced. Then here you look to the tibia, which looks sclerotic with ill definition of the cortex from the medulla. Compared to this area, the medulla is well defined from the cortex in this sound area. By MRI, you see there is a marrow infiltration, extraosseous soft tissue component, and in the axial image, you see the marrow infiltration compared to the marrow of the fibula. Then one of the rules that I used to say is whenever you see a destructive lesion in the pelvis, if this patient is in the pediatric age group, suspected the possibility of Ewing sarcoma. If he is adult, suspected the possibility of metastatic disease. Then a destructive lesion in the pelvis, especially if it is associated with bone sclerosis in the pediatric age group, is highly suggestive of Ewing sarcoma. Why both lesions are put in this group, particularly in this category, the Ewing sarcoma and the chondrosarcoma? Actually, if you look to the Ewing sarcoma and the osteosarcoma, you may suspect the diagnosis, but you don't reach the final diagnosis unless you have the biopsy. And very frequently we diagnose Ewing sarcoma and it proved after biopsy to be an osteosarcoma. This is true in the real practice. That's why I put these two tumors in this category, because you cannot reach the diagnosis before the biopsy for sure. The chondrosarcoma is an easy if it shows the classic configuration, which is a malignant mass showing the malignant criteria. The cortical destruction is extraosseous soft tissue component, and the soft tissue component contains calcium. And calcium is the diagnostic hallmark of the chondrosarcoma. Calcium, of course, is diagnosed better by CT rather than plain X-ray and MRI. And the chondrosarcoma may be primary and may be secondary. Secondary on top of osteochondroma, like in this case. Secondary on top of Ollier disease or enchondromata, on top of Maffucci syndrome, or on top of diaphyseal achalasia or multiple osteochondromatosis. The next lesion is the aneurysmal bone cyst, which is diagnosed by this criteria, which is the presence of multiple fluid levels. And this is in a specific value for MRI. Sometimes you can see the fluid levels by CT, but MRI is good for assessment of this fluid. This is an expanding lesion in the distal part of the humerus. Then this lesion may represent a giant cell tumor, may represent a simple bone cyst or aneurysmal bone cyst. Then the detection of fluid levels inside the lesion is helpful to reach the diagnosis. And this is a classic appearance of an aneurysmal bone cyst in the spine. And you can see the multiple fluid levels in the expanding lesion affecting the pedicle, the lamina, and part of the vertebral body. It extends also posteriorly, as you can see. Then this is an aneurysmal bone cyst of the calcaneus and diagnosed by the presence of these fluid levels seen in the CT image. Another aneurysmal bone cyst of the distal part of the femur showing the classic fluid levels inside the aneurysmal bone cyst. The simple bone cyst is diagnosed by being a unicameral cyst, meaning it is a cyst with a single cavity. And this cyst with a single cavity usually occurs, 90% of this simple bone cyst occur in the proximal femur and the proximal humerus. These are the major sites for the simple bone cyst. And you may use the MRI to see that the cyst is formed of a single cavity. There is no internal septations and no loculi and no fluid levels inside. And frequently in the books you see this characteristic image with a simple bone cyst, and this arrow points to a bone fragment that has resulted from this pathologic fracture, and because of the absence of internal septations, the bone fragment is in the bottom of the cyst. This arrow points to this fragment, indicating that this is a simple bone cyst, not an aneurysmal bone cyst. Then you came to the metastatic deposits, which is an easy diagnosis if you know that the patient had a primary malignancy. And metastasis usually osteolytic, but maybe osteosclerotic or mixed. If you have mixed lesions or sclerotic lesions, you are in the way of metastasis, because multiple myeloma does not produce sclerotic lesions except very rare. Then you see multiple osteolytic lesions in the vertebral body and in the iliac bones, and with positive bone scan, because in the myeloma cases the bone scan is negative. Then if you see a solitary dense vertebra, this is the differential diagnosis: metastatic deposit, lymphoma, and Paget disease. You know that Paget disease causes enlargement of the affected bone. And if the vertebra is in size similar to the above or below vertebra, you can easily exclude the Paget. Then you are left with deposit and lymphoma. If you see multiple sclerotic lesions like these lesions scattered through the vertebrae, then you are dealing with sclerotic metastasis. And using the multi-detector facility, you can have this image, which is helpful in the follow-up. You can easily identify the affected vertebra in a single image, and you can follow up the lesions if they are regressive or progressive. Then I always say that the detection of metastatic deposits by MRI in the spine is much better in the T1 weighted image without contrast injection. And this is the proof. This is the metastatic deposits in the T1 and the T2 and after contrast injection. The most detectable lesions are seen in the T1 weighted image before injection of contrast. After injection of contrast, the lesion enhances, then will be masked by the normal signal of the bone. And the T2 weighted image, whenever the lesions are raised in the signal, they are near to the signal of the normal bone marrow, then you can hardly see the lesions. Then whenever you see a lesion like this, which is black in the T1, T2, and this is a sclerotic metastasis with extraosseous soft tissue component anterior and posterior to the vertebrae. Then what are the features suggesting the diagnosis of metastatic deposits? Multiple lesions, especially if mixed and variable size, because the myeloma lesions are usually close to each other in size. But if you see sclerotic and osteolytic lesions, this is helpful in the diagnosis of metastasis. Then destructive lesion in the vertebral body without disc space affection. If you see a vertebral body destruction, the first possibility in adult patients is metastatic deposit. And even if this lesion affects the neural elements, it is also metastatic deposit. Then what is the policy if you diagnose metastatic deposit in the spine? Don't perform bone scan or CT scan or go directly for the biopsy to know the primary site of the lesion. Then if you see osseous lesions associated with deposits elsewhere, like deposits in the lung or deposits in the liver, or if you see a destructive lesion in the iliac bone in an adult, like this male 73 years old with a destructive lesion in the right iliac bone, which has been proved by biopsy to be metastatic deposit. The myeloma lesions are usually osteolytic. They give negative bone scan finding. They usually are of almost similar size to each other, and they are absolutely osteolytic. Then you can diagnose the lesions by the presence of characteristic proteins in urine, and you can see these lesions by CT or by MRI. In the plain X-ray, you can see osteopenia of the vertebral bodies and partial collapse of, like this one, you see a partial collapse of L5 and this D12 or L1 vertebral body as well. But the CT is impressive. If you see this finding, numerous osteolytic lesions that are near in size to each other, affecting the vertebral body as well as the neural elements, the spinous process, and the iliac bones as well, then you are in the possibility of multiple myeloma. Then you came to the last group of the lesions, which include the fibrosarcoma, fibrous histiocytoma, chondromyxoid fibroma, adamantinoma, and the lymphoma. We start by the fibrosarcoma, and this is the fibrosarcoma of the fibula. If you look to this plain X-ray, you can easily say that this is a malignant tumor because there is cortical destruction and the extraosseous soft tissue component. But you cannot say this is an osteosarcoma or Ewing sarcoma because of the epiphyseal closure. And this is an older patient above the age of the Ewing and osteosarcoma. Then you say this is a malignant tumor and go directly for biopsy to see what is this one. And this is another case. You see a destructive lesion in the lower part of the femur. The MRI showed the destruction of the lesion with extraosseous soft tissue component indicating its malignancy. Then by biopsy, it appeared to be a fibrosarcoma. And this is a fibrous histiocytoma which affects the tibia with a skip lesion in the distal part of the femur. These images are obtained from the literature, and it proved to be a fibrous histiocytoma. Then this is a benign lesion, which is the chondromyxoid fibroma. The chondromyxoid fibroma, if it occurred like this, you can spot the lesion. What is this appearance? It is eccentric position in the metaphysis of the long bone after epiphyseal closure. This lesion does not reach the articular cartilage, so that you can differentiate it from the giant cell tumor, and it may affect the flat bones. Calcification is not common, but you may see some calcium, and you see very sharp endosteal margin. The margin is very clear, especially if you perform a tomographic section. This lesion has no malignant characters, but if it is removed, it may recur in 10% of cases, and the differential diagnosis is by the chondroblastoma. Chondroblastoma occurs in the epiphysis before epiphyseal closure. This is more or less a metaphyseal lesion. It is not an epiphyseal lesion. Adamantinoma, it occurs in only two sites in the human body, in the tibia and in the mandible. In the tibia, it usually affects first the anterior aspect of the tibia, then affects the whole tibia. And if you see a lesion like this, one of the diagnostic possibilities of lesions, destructive lesions affecting the anterior aspect of the tibia, is the adamantinoma. But you can never reach the possibility unless by biopsy. Then the primary bone lymphoma, you remember that solitary metastatic deposit may represent solitary dense vertebra may represent deposit or lymphoma or Paget disease, and lymphoma is one of these possibilities. I used also to say, if you see a bone marrow infiltrative lesion that is encasing the iliac bone, encasing, meaning that this lesion is surrounding the iliac bone from all directions, then you may put the possibility of lymphoma. And you see, lymphoma is different from metastasis. Metastasis is destructive and it produces an extraosseous soft tissue component, but here you can see that the lesion is almost encasing the iliac bone with infiltration of the bone marrow. If you have a CT scan and you can identify some sclerotic reaction in the tumor, this is a very helpful sign for the diagnosis. But if you have this MRI in a male 40 years old and you got infiltrative lesion of the medullary cavity with extraosseous soft tissue component, you say this is malignant. But which one of the malignant lesions? You go to biopsy to see the possibility. And this is one of the appearances that I can see frequently in the clinical practice. A tumor which is infiltrating the bone marrow of the iliac bone and encasing the iliac bone all around, and it has been proved to be a non-Hodgkin lymphoma. Then finally, what are the characters of a benign lesion? A benign lesion has a well-defined margin, has a sclerotic rim, is an expanding lesion. Most of the expanding lesions are benign. There are few malignant lesions that are expanding, including the plasmacytoma and some types of metastatic deposits. Then there is no periosteal reaction and no extraosseous soft tissue component. And this is the list of the expanding bony lesions all over the skeleton, and can be remembered by this abbreviation, which is known as phygnomachic. And phygnomachic stands for these: fibrous dysplasia, enchondroma, giant cell tumor, non-ossifying fibroma, osteoblastoma, myeloma, aneurysmal bone cyst, simple bone cyst, brown tumor of hyperparathyroidism, hydatid cyst, and chondroblastoma. And you know, some of these phygnomachic are not bone tumors. Then the malignant lesions are characterized by ill-defined margin, cortical destruction, periosteal reaction, extraosseous soft tissue component, and this intra-articular invasion and neurovascular affection are the sequelae of extraosseous extension. And this is the classification of bone tumors written in the books. You have three types of cells: the osteoblast, the chondroblast, and the fibroblast. Benign lesions of the osteoblast include osteoma, osteoid and osteoblastoma. The malignant one is the osteosarcoma. The chondroblast, inchondroma, and chondroblastoma. The malignant one is chondrosarcoma. The fibroblast, fibrous cortical bone defect. Non-ossifying fibroma, fibrous dysplasia, sometimes is included within the category of bone tumors, and the malignant part is the fibrosarcoma. And there is an intermediate lesion between these two and an intermediate lesion between these two. This lesion is the osteochondroma, and this lesion is the chondromyxoid fibroma. And the remaining 6 lesions are the simple bone cyst, aneurysmal bone cyst, and giant cell tumor, the multiple lesions, multiple myeloma, metastatic deposits, and the lymphoma. What do you think about this lesion? Mumtaz. Very good. And this lesion, giant cell tumor. Very good. And this lesion, sclerotic lesion in the pelvis, in الإيدج مش قوي لكن this lesion has been proved to be Ewing sarcoma. Yes. Okay, this is the calcaneus by plain X-ray and by bone scan. There is hot uptake in the calcaneus and the talus as well as the distal part of the tibia. Do you want to see the MRI? Okay. Do you think this lesion with the characteristic findings or non-characteristic finding? None. Can you say this is a benign or malignant? Benign or malignant? Marrow infiltration means malignancy. Marrow infiltration means malignancy. And you got multiple bony affection, the calcaneus, the talus, and the distal part of the tibia. Marrow infiltration means malignancy, and this has been proved to be lymphoma by biopsy. The suggestion of lymphoma can be made from the plain X-ray by remembering that lymphoma produces some sclerotic reaction in the bone affected by the lymphoma. Then what do you think? Multiple inchondromata or ear disease. Okay, which part of the human body, this area?
There are 2 bones.
There are 2 bones. Yes, very good. Okay. Osteochondroma, fibrous cortical bone defect. Okay. Whenever you see this bone marrow infiltration in the spine, number 1 is metastasis. Number 1 is metastasis. Because metastasis is much more common than lymphoma in the spine. Chondrosarcoma آخر كلام. Chondrosarcoma آخر كلام. Okay. And this is an osteochondroma of the spine. It's very rare in the spine, but this is a beautiful example. And they see an exostosis with a cancellous bone, which is continuous with the medullary cavity. Then what do you think about this? Which bone is affected, the tibia or the fibula? The fibula. By benign or malignant? Malignant. Yes, malignant. With sun ray speculations, you can see this is an osteosarcoma of the fibula. Yes, giant cell tumor of the ulna. Okay, very good. Hemangiomas, soft tissue hemangiomas with philippuli scattered in the arm. They scattered in the thigh. The femur is okay. There is no abnormality in the femur. This is the soft tissue hemangioma. Okay. This is a destructive lesion in the distal femur. Do you think this is a benign or malignant? Malignant. And it proved by biopsy to be a leiomyosarcoma. How can you know? This is a malignant lesion. This is what we can say. What do you think about this case? ماله؟ اكزوستوزس. هنا باينة كويس. ايوه. طب بص كده. What do you think? Yes, diaphyseal aclasia with multiple in diaphyseal aclasia, hereditary exostosis. What do you think? And simple bone cyst. Okay, if you see an expanding lesion in the proximal humerus or in the proximal femur, you put first possibility simple bone cyst because this is the main site for the simple bone cyst. If you failed to discover that this is a single cavity, then put the other possibilities. What do you think of this lesion? Osteosarcoma. Then look to the MRI of the same case. Yes, aneurysmal bone cyst. This is an expanding lesion, and it has been proved to be an aneurysmal bone cyst. Yes. 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 This is unusual appearance of the aneurysmal bone cyst. This is a male patient, 11 years old. Ewing sarcoma, most likely, and there is a tumor infiltrating the marrow with extraosseous soft tissue component. The axial images shows circumferential tumor around the shaft of the femur, typical of an Ewing sarcoma. Enchondroma, yes. A bone infarction is like the Chinese figures. Yes, you remember this. In this morning we said about the bone marrow infarctions is like the Chinese figures. This is a cluster of calcification which is classic for an enchondrome. What do you think of this radius? Benign or malignant? Benign. Okay. Which type of benign lesions in this fibula in this age? In this ulna, radius asif, in this radius, in this age? You may think about fibrous dysplasia, for example. Yes? No? Okay, let us look to the MRI. Is it benign or malignant? Malignant, because of the bone marrow infiltration and the extraosseous soft tissue component. Can you guess what kind of malignancy? And this was lymphoma. Okay, do you see the lesion? Yes, chondroblastoma in the epiphysis of the proximal tibia. Do you see this lesion in the head of the fibula? Yes, it is an expanding lesion with female 59 years. Yes, 59 years old. And you see the marked increased uptake in the lesion by bone scan. Malignant giant cell tumor. And if you know that the patient had breast cancer, and this is one of the rare types of expanding metastasis. This is metastasis, and it is in the distal part of the limb, but an odd site for metastasis. Then what do you think about these lesions? Fibrous dysplasia, metastasis. Multiple osteolytic lesions in the femur, in the iliac bones. Yes. Metastasis and multiple myeloma are in the differential diagnosis. How can you separate both? Whenever metastases in the flat bones occur, they destroy the cortex, especially if they are large and they are multiple. But if you see that lesions are almost of similar size to each other, they are all osteolytic, no sclerotic lesions. And if the patient had no history of primary malignancy, then you can suspect the possibility of multiple myeloma. If you are in doubt, go to the CT scan or MRI. Then these are multiple lesions, one in the pelvis and one in the chest wall and another one here. What do you think? Deposits, lymphoma, myeloma. If you take my rule and you consider all the lesions in the pelvis as metastatic deposits, and you consider all these also as metastasis, and this was the case as metastasis, and I thank you very much.